Hi everybody, and welcome to our module on restrictive cardiomyopathy. Restrictive heart disease is the name for a group of disorders where something infiltrates the myocardium. In fact, these disorders are sometimes also called infiltrative cardiomyopathies. The substance that infiltrates the heart is different in different diseases. For example, in sarcoidosis, granulomas infiltrate the left ventricle. In amyloidosis, it's amyloid protein. But in all of these conditions, the common theme is that because of this substance infiltrating the myocardium, the heart cannot relax and fill. And therefore, these patients develop severe diastolic dysfunction. They typically have a normal ejection fraction because there is no problem with contractility. The problem is with the ventricle relaxing and filling with blood, and therefore diastolic heart failure ensues. So patients with restrictive heart disease will develop the usual signs and symptoms of heart failure like pulmonary edema and elevated jugular venous pressure and lower extremity pitting edema. But let's talk about what their hearts will look like when you do an imaging procedure like an echocardiogram. First of all, you should know that the hearts of patients with restrictive heart disease have a normal left ventricular ejection fraction. Normal is greater than 55%, and that's what you'll see in patients with these disorders. In addition, if you measure the left ventricular volume, it will be normal. In other words, the hearts of these patients are not dilated like they are in dilated cardiomyopathy. Now, because there is restricted filling of the left and right ventricles, this leads to high atrial pressures. In other words, blood can't get out of the left and right atria, so the pressure in those chambers gets high. This results in enlargement or dilation of the left and right atria. So the classic findings in a patient with restrictive heart disease on imaging are normal left ventricular size and function and massive biatrial enlargement. This is really the key because those pressures are really high in both of the atria. Let's talk a little bit more about the clinical features of restrictive heart disease. So in restrictive cardiomyopathy, there is impaired filling of both ventricles, the right ventricle and also the left ventricle. And this can lead to signs of right and left heart failure, like I talk about in the video on heart failure basics. But one thing you should be aware of is that in restrictive cardiomyopathy, the right ventricle is affected much more than the left ventricle. In other words, the right ventricle is very sensitive to problems with impaired filling. Therefore, in restrictive cardiomyopathy, there is often prominent right heart failure in terms of signs and symptoms. So patients with this condition often have dyspnea, especially on exertion, because their right ventricle is not pumping blood to the left ventricle. And they often have prominent clinical features of right heart failure. So they can have markedly elevated jugular venous pressure, there may be lower extremity edema, and there may even be congestion of the liver. Sometimes restrictive cardiomyopathy leads to cirrhosis. This is called a nutmeg liver because chronic congestion of the liver causes it to take on the appearance of a nutmeg, which I've shown on the screen here. So what you should be aware of is that restrictive cardiomyopathy often looks a lot like liver disease. Patients can have a distended abdomen with a big liver. They can have lower extremity edema, which you might think is from portal hypertension. But the one feature that clinches the diagnosis of restrictive cardiomyopathy is the elevated jugular venous pressure that should never be present in pure liver disease. And in real life, sometimes patients with cirrhosis are misdiagnosed as having liver disease when what they actually have is restrictive cardiomyopathy. Restrictive heart disease is very rare, so often the diagnosis isn't considered and the patient will be suspected to simply have liver disease. In the video on heart failure basics, I talk about how to examine patients with heart failure and estimate the jugular venous pressure. In restrictive heart disease, the jugular venous pressure is often elevated, as I just told you on the last slide. But in addition, it often has a special feature that's called Kussmaul's sign. This means that when the patient inspires or takes in a breath of air, there is a rise in the jugular venous pressure. Normally, when you take in a breath of air, the jugular venous pressure falls. But what you see in patients with restrictive heart disease is that it rises. And the reason it rises is because the ventricle cannot accept the extra venous return that occurs with inspiration, and therefore instead of more blood volume going into the right ventricle, it goes into the right atrium in the venous system and the jugular venous pressure rises. That's called Kussmaul's sign. It's a classic finding in restrictive heart disease. So just to make this very clear, let's imagine that we have the right ventricle here. This is the tricuspid valve. Here's the right atrium, and the venous system is pouring blood into these two chambers. When a patient takes in a breath, blood enters the right ventricle, and normally the right ventricle is stretchy and flexible, and it's able to fill more and accept this increase of volume. In a restrictive cardiomyopathy, however, the right ventricle is very stiff and rigid, and therefore when this extra volume tries to go inside, it can't fit. So it shoots backwards into the venous system, and that's what you're looking at when you look at the neck, and thus you see a rise in the venous pressure when a patient takes in a breath of air, and that's called Kussmaul's sign. Rhythm disturbances are also common to many forms of restrictive heart disease. Substances that infiltrate the myocardium can disrupt electrical activity. This can potentially cause arrhythmias, sometimes dangerous arrhythmias like ventricular tachycardia, which can lead to sudden death, but in addition, other arrhythmias can occur. This can also lead to various forms of AV block, such as third-degree AV block, as I've shown on the bottom of the screen here. For the remainder of this video, I'll go through the major specific causes of restrictive heart disease, and we'll start with amyloidosis, which is the classic cause of restrictive heart disease. I have an entire video on amyloidosis in the hematology section, but by way of review, in all of the amyloidosis disorders, amyloid proteins deposit in tissues in the body, and when they deposit in the heart, that can lead to restrictive heart disease. Amyloid protein deposition leads to formation of apple-green biorefringents on biopsy specimens as shown on the screen here. There are various forms of amyloidosis, a primary form, a secondary form, and so forth. But the point here is to remember that when amyloidosis involves the heart, that classically leads to restrictive heart disease. In some forms of restrictive heart disease, including amyloidosis, there is a classic sign of a thickened myocardium on imaging of the heart, but low voltage on the surface EKG. If you look at the bottom left side of the screen, this is an echocardiograph image of a patient of mine with cardiac amyloidosis. And you may not be able to appreciate this if you're not used to looking at these pictures, but this patient has a very thick myocardium. Now on the right side of the screen is that same patient's surface EKG. Note that the voltage in the QRS complex is very small. For a patient with a thickened myocardium from left ventricular hypertrophy, normally the QRS complexes are enormous because those hypertrophied myocytes are generating lots of electrical activity. In this case, we have thickened myocardium but low voltage, and that's because the myocardium is not thick due to hypertrophy, it's thick due to deposition of amyloid proteins. And this is a classic finding, thickened myocardium with low voltage on the EKG that can be seen in amyloidosis. It's also seen in Fabry disease, which we'll talk about in a minute. Another potential cause of restrictive heart disease is sarcoidosis. I have a video on sarcoidosis in the pulmonary section, but by way of review, sarcoidosis involves granuloma formation that usually involves the lungs, but there can be extrapulmonary involvement, including in the heart. Fabry disease I mentioned before, it's a lysosomal storage disease that I talk about in the video on lysosomal storage diseases in the biochemistry section. It's caused by a deficiency of the enzyme alpha-galactosidase A and accumulation of ceramide trihexoside in tissues, and it can involve the heart, and it classically involves restrictive heart disease and left ventricular enlargement. I talk about hemochromatosis in the GI section. It's a disorder caused by iron excess, and the iron can deposit in the heart. Now, usually this causes the left ventricular ejection fraction to fall, and the patient will develop a dilated cardiomyopathy. However, in some rare cases, it can cause a restrictive cardiomyopathy because of the iron deposition in the myocardium. Restrictive heart disease can develop post-radiation when patients receive radiation therapy for treatment of tumors. Acutely, radiation therapy can sometimes cause inflammation, but over time, this can lead to fibroblast recruitment and extracellular matrix deposition, especially things like collagen and fibronectin, and these substances can lead to a restrictive heart disease picture. So shortly after radiation therapy, patients can potentially develop pericarditis from the acute inflammation. But long term, there are a number of other effects that the radiation therapy can have on the heart. First of all, patients can potentially develop chronic pericardial disease, including restrictive pericarditis. They can also potentially develop coronary artery disease or valvular disease or conduction abnormalities. But one of the potential long-term consequences of radiation is a restrictive cardiomyopathy, as I just mentioned. This is from fibrous tissue accumulation in the heart and diastolic dysfunction. A rare condition that can potentially cause restrictive heart disease is called Loeffler syndrome. Whenever you hear the word Loeffler, you should picture an eosinophil in your mind. In fact, I used to remember that the E in the name Loeffler stands for eosinophil. Loeffler syndrome is an example of a hypereosinophilic syndrome. These patients have very high eosinophil counts in the peripheral blood, and they develop symptoms because the eosinophils infiltrate their organs. It often involves the skin. These patients often have eczema. It also often involves the lungs. These patients develop fibrosis, but it can also involve the heart and cause restrictive heart disease. Hypereosinophilic syndromes like Loeffler syndrome can be a primary disorder. These are neoplastic disorders where either stem cells, myeloid cells, or eosinophils become neoplastic and proliferate in an uncontrolled manner. They can also be a secondary disorder. The eosinophilia can be reactive. This is eosinophil overproduction due to cytokines. This can be seen in parasitic infections. So patients who have chronic parasitic infections have an eosinophil response, and this can lead to a hypereosinophilic syndrome. One of the classic disorders to do this is Ascaris lumbricoides, which I discuss in the infectious disease section. Some patients also develop a secondary hypereosinophilic syndrome in response to tumors or lymphomas. And then finally, for many patients, they simply have an idiopathic hypereosinophilic syndrome where the cause is not clear. In these disorders, eosinophils can infiltrate the myocardium, and in fact, this is a common mode of death in hypereosinophilic syndromes. When this first happens and the myocardium first is invaded by eosinophils, this can lead to inflammation and myocarditis, although this phase is often asymptomatic, so patients are unaware it's going on. They then develop the chronic phase where there's endomyocardial fibrosis and myocyte death. This can lead to a restrictive heart disease pattern, but then one thing that's important to know is that eosinophils like to infiltrate the endomyocardial layer. That's the layer right below the blood in the chambers. This causes inflammation to be occurring right at the interface of the myocardium and the blood, and that's a setup for a thrombus formation. So thrombus can form in the chambers of the heart, and this can lead to an embolic stroke in patients with a hypereosinophilic syndrome who have involvement of the myocardium. The final cause of restrictive heart disease I'll mention in this video is a rare condition that occurs in babies called endocardial fibroelastosis. As the name implies, this condition involves thickening of the endocardium. This is the layer I mentioned on the last slide. It's the innermost myocardial layer. It's the layer that interfaces with the blood in the ventricular chamber. This develops due to an unknown cause in infants in the first year of life. They will have a thickened myocardium on imaging of the heart, and the reason the myocardium is thick is because of proliferation of fibrous and elastic tissue. That's why it's called fibroelastosis. In particular, you can see collagen, but you can also see other fibrous and elastic fibers if you do a biopsy of the ventricle. This can lead to a restrictive cardiomyopathy picture, although it can also lead to many other heart problems. Some of these children have a reduced ejection fraction. Some of them also have concomitant congenital heart disease, but the point you want to remember for step one is that this is a cause of restrictive heart disease in babies due to thickening of the endocardium from proliferation of fibrous and elastic tissue. And that concludes our video on restrictive heart disease.